Hello, hello, everyone. Welcome, welcome, welcome. I always want to say good morning, but I know it's not morning for everybody. And then we have so many international viewers. So for sure, I don't think it's morning for y'all. I think it's like evening or afternoon. So thank you, everyone, for coming. So I always have to start off by saying this is such a labor of love. Liz is one of my favorite people on the planet who, as soon as COVID goes away, better come out to California. Actually, she has a baby, so I should probably
You
go
better
out
come to
there.
me.
I was going to say, traveling with a baby is probably a pain. But, Liz and I, just to give a little background on us, I mean, we're both clinicians that specialize in OCD, but we are obviously super passionate about advocacy. I think that's where our hearts lie. And as individuals with OCD, we come to you both with clinical insight and also personal experience. And so Ask the Experts really came out of a demand from you all. When we would have an extra Wednesday of the month, we would do a Q&A, and it got to a point where we had to start doing part 2, 3, 7 because we got so many questions. And when it was time to kind of revamp the live stream and virtual programming schedule for the year, it just made sense. So we are both happy to come from you from different parts of the country. I'm out here on the West Coast. We got Texas holding down, but we always like to hear where you're all from. I always get giddy and excited to hear that everybody's from all over the world. It just shows that our OCD community is strong. So thank you, everyone, for coming to this edition of Ask the Experts. So we have a ton of questions. Remember, you can always pre-submit questions. You can either go to iocdf.org/peace of mind. That community right there gives you an opportunity to suggest topics, which, by the way, we've absolutely been listening to those. We just had a meeting and we're going to do some lunch and learns based out of your suggestions. And you can ask pre-questions. But we have so many from recent lives. We also love to get live questions and interact with you in the chat. So please don't hesitate. You can definitely throw in some questions on whatever social media platform you're following us. So we're absolutely happy to have you today. Before we jump in, I want to make a couple announcements. First and foremost, remember that we are not a crisis hotline. If you are absolutely in a crisis, we want you to make sure to call 911, go to your nearest emergency room, or call the suicide prevention hotline, which usually pops up down there because I don't have it memorized. There we go, 800-273-8255. We're here to give you clinical insight, to answer questions, to facilitate a conversation. But if you're at that point where you think you're a danger to yourself, please, please, please use those tools. Also, we just want to let you know that when you ask the questions, and this conversation is recorded so that people can access it later, and we want to remind everyone to please be respectful. So without further ado, make sure you're announcing where you're from and also start with questions. So Liz, how are you doing today?
Doing good. Excited to be here. I feel like, I don't know, I can't believe we're in February. So I'm excited. It's weird to be like, oh, we're a month in. I feel like Chris and I were just saying a second ago that we always start these Ask the Experts like, what are we going to get to? And then we pull up all the questions and we're like, oh my gosh, how are we going to have time to get to everything? So I'm just excited and ready to hop in with you.
Yeah, absolutely. We already got our first question. Well, first of all, hi, Dave. It's always good to see you. We see Aaron Toth, and we have Aaron from Michigan. But Dottie already asked us a question. Could you give advice on anger and OCD? I believe we did a talk on this to a packed house at a conference one year. And it seems to be such a hot topic because there is such an element of anger and frustration, and it definitely negatively impacts family. So maybe you could start there. You did such great advice at the OCD SoCal conference about this topic.
Well, I think this is something that's personal to Chris and I because we both dealt a lot with this, and so I think the first piece is to know more about the individual case, right? So for example, is it an adolescent who might struggle with understanding their emotions and understanding how to process what's going on, and it may often come out as anger, right? Or is there comorbid anger stuff going on? Sometimes we also see anger really increased in a PANS PANDAS case with OCD, where there's this kind of like anger and rage that happens. So of course we want to know more individually about what's going on. But the reality is that most anger, unless it needs specific specialized treatment, something different like DBT or specific anger work, it can be addressed in OCD work because it's typically going to be a behavioral intervention, right? And what we do know is that anger, much like depression, if it is secondary to OCD, we should see it decrease when OCD symptoms also decrease, right? But one of the things I always want to talk about is where's the anger coming from and what is the root of it? Can we get to the root cause? But also, can we start to think about better ways to express our emotions, right? Often anger is an emotional response, and OCD makes us feel really emotionally exhausted, confused, right? And so it makes sense that we turn to anger, or that's how we lash out. So there's a lot we want to kind of break down and better understand about it. But what I will say is that it's very common. It's pretty rare that I would ever see someone with OCD who doesn't ever get short, snappy, or have anger issues. And in children and adolescents, even much more common with parents. And so that is why, if we're talking about a child or adolescent, we really should be doing combined treatment. The family needs to be actively involved.
Yeah, and some of the things that I think about in my own case, and then obviously working with clients, is a lot of times, especially if they're young, especially if they're kids, especially if they're teens, but even if it's in a young adult or an adult, the difficult thing with OCD is that we aren't used to handling that level of intense stress as people consistently. I mean, with OCD, you can be re-triggered minute by minute, hour by hour, and so it just takes a toll on the system, and the individual just has no wherewithal to handle any of life's stressors. So then if they're in the middle of a compulsion and somebody jumps in, or there's a leak in the house and there's financial issues and the OCD and all these things going on, it's not that obviously we're not approving that anger should be the way that people express their emotions, but it just gets to a point where the person just kind of goes to that primal emotion and just lashes out. And so Liz made a good point. I mean, for me, in my anger, that really started to fade once I knew what I was dealing with and had proper treatment. And so what I tell people is, the individual with OCD, a lot of times it's that they have no hope, and they really think that they have to constantly struggle with this, and they don't know that there's treatment. So when loved ones around them really start to take the disorder seriously and say, look, somebody's really, really struggling with this, let's jump in and get them resources. Let's, we hear that you're really struggling. Let's figure out ways that we can get you help. Let's support you in the proper way. What we start to notice is that the person feels a love, they feel attention, they feel like there's something that can help them. And I know for me, a lot of my anger decreased, and I see a lot of my clients' anger decrease once that they know there's hope. The other point, maybe Liz, if you could touch on a little bit, and it really spoke to me, and it was man, I wish she would have been here when I was going through my worst. You talked a little bit about using DBT, dialectical behavioral therapy, and it really just spoke to me because when I was a teenager going through OCD, I did not have the tools to know how to express what was going on in my head. So for me, especially in society, it's males, you can be angry. That's an okay emotion. It's all I knew was anger. And so could you speak on that? Because I really was dang, where was Liz? And then I'm oh yeah, she's younger than me. She was probably
but
a
also
freshman in high
DBT,
school.
no, DBT wasn't there when I
know.
was struggling either, right? So I think both of us, our timeline is pretty similar, and it wasn't really around. We didn't understand it. But DBT is dialectical behavioral therapy, and it is a specific intervention that really is used for emotion regulation. And so when we find individuals who might be struggling with emotion regulation, they find themselves often dysregulated, and maybe even behaviors lead to self-destructive behaviors such as self-harm or suicidality. DBT is really our go-to intervention. It is the most evidence-based and we know effective for these sort of thoughts. And so what we'll find, actually, Ethan talks a lot about DBT being a part of his treatment journey. And what we find is that DBT is often used in conjunction with ERP. Sometimes it's used prior, right? Both Chris and I have a lot of clients who will say, hey, we want you to get some DBT skills first and then come back to us. And it's not because ERP won't work, but when you think about ERP, we talk a lot about ERP. And one of the feedback we get from people is well, what if ERP doesn't work? Or what if we can't do ERP? The goal is to engage in readiness for ERP. And so for some people, that might be DBT. And what I mean by that is when you think about the concepts of exposure and response prevention, the concept of treatment is literally to dysregulate you, right? What we are doing to help get you better and help get you over your fears is making you anxious, is dysregulating you. It's attacking and addressing these fears head on that you've been avoiding. And so it's scary, it's activating, and it emotionally dysregulates us. If our emotion regulation tools are really poor, we are going to struggle even more with being able to engage in ERP, and it could lead to risky behaviors. And so DBT can be an incredible tool. It wasn't around when we were there, and I know it would have been useful for both of us. I can remember when I was in treatment, they sent me to anger management group, and I remember really struggling because I was why am I here? These individuals none of them had OCD, and like I couldn't relate to what they were going through because my anger was secondary to my OCD. But looking back, I'm like, man, DBT skills would have been great.
Yeah, no, and I got the same thing. I got sent to anger management as well as like a because one of all my first therapists were an OCD specialist, and the anger would always come up from my family, and so that was my first thing, and it was so hard because they kept saying like, "What are you angry about?" And I'm like, my brain just tells me a lot of messed up stuff, and it won't go away, and so the anger management wasn't very helpful. What I always tell people too is if you have a loved one that is in treatment and just doesn't know how to regulate, like Liz is saying, that's where those DBT skills come in because the person can start to self-regulate. So if they are triggered, they're not going to go straight for the jugular. I think this topic's great. I see a lot of people in the chat really engaged with that, and we can always address this. I would say the last thing is if the anger is in a family system, Barbara Van Oppen out of USC does a lot of talks about family accommodation and contracting, and that's something that can be really helpful if you have a therapist, or even if you don't have an OCD therapist, the second best thing would be a therapist in general to mediate and coming up with a contract. And what that would look like is at a time when nobody's stressed, really sitting down and saying, okay, what are we going to do when it comes around somebody giving into compulsion? So, if you have a son or a wife or a husband or something that is in the bathroom taking 3-hour showers, and then when you pound on the door, it turns into a big screaming fight and anger and breaking things, that's not working. So let's come up with a different system so that when somebody is struggling, we all have come to the table and all agree on how we're going to handle that. And that can often help in those really triggering situations.
Absolutely. And I know there's some questions about RO, DBT, and others. And so I know this is not necessarily Chris and I's specialty. And so what we may do is a lunch and learn specific on DBT and bringing someone in and some individuals who do DBT and OCD work who can really talk about the differences in all the different DBT interventions. And then we're hearing great feedback from others saying DBT is the best and that it can be helpful. So Chris, let's hop into some pre-submitted questions as well. Remember, you guys, if you have any questions throughout today, please put them in the panel or the pane on the right-hand side. And hi to everyone. I love seeing folks from all over. We have people from Dublin, India, the Philippines. So thank y'all for joining. All right. So the first question, Chris, is my husband has OCD and anxiety and is constantly worrying about issues such as the maintainer, upkeep of our home, our money will run out, and it's truly giving me anxiety. Is there a support group for me? We are both in our late 60s.
Yeah, so I'm sure there's other ones out there. I just don't know them. But actually, my mom and I and another therapist run a free family and loved ones OCD support group. It's open to everybody. It's not based out of my treatment center. It's something that my mom actually was running through NAMI, which is the national, NAMI, National Alliance in Mental Illness. But my mom was running a support group for adult children with OCD. And unfortunately, it was up in Los Angeles. And the person who was letting us use the house ended up moving. But now we run it here in Orange County. But since the pandemic, it's been virtual. So if you're interested in that, I'll go ahead and put the best email to email at. It's just my mom's Gmail account. So I'm going to put that in the private chat and you can also email OCD SoCal also. But real quick, just about ours, and then just talking about family support in general. We have it now. It's free. It's virtual. It's, Liz and her family were gracious to come to last month. She's going to be back this month answering questions. We usually have about 60 to 90 families attend. So it's a really great support group for families. And it gives family members, loved ones, neighbors, whoever is there to support an individual with OCD, an opportunity to just get support and get clinicians that are going to be able to answer questions. We have other families answering questions. If there is anybody that knows of any other family support groups, ours is virtual, so anyone can go. But if you want an in-person one or one in an area, we'd love to have it in the chat. But also you can always go to iocdf.org/find-help and search in your area, and it'll show you support groups. But it is great to come to a family support group because, as you know, you're really stressed out because you see your husband dealing with anxiety and worrying and trying to keep up with the house and most likely OCD and all these other things. And often we feel helpless to help our loved ones. And we have to find that fine line of like either doing too much or too little. And so it is kind of a tightrope walk. So please find some support for you. Sometimes even going to a therapist who understands OCD and related disorders to give you support on how to help your loved one. But definitely find a support group either through the IOCDF. You can always join ours, or if your local, treatment center has one, that might be great for you as well.
Absolutely. And the last thing I'll say too is remember, you can always seek individual therapy as well. So if you are finding that like it's becoming hard for you and you're starting to experience symptoms of anxiety, like you could also work with an individual therapist, not just for yourself, but to also think about how to better support him and create boundaries. But also want to normalize that we do find anxiety increasing, especially as individuals start to reach like retirement age and different transitions in life around these specific things. So there are specific interventions, and I'm sure some specific anxiety-based support groups that we may know of through IOCDF, but you could also check out ADA.org and see what resources they might have.
Yeah, Beth says that she's writing a book on OCD and wants to know if they could mention both of us. And I say we give the okay. We're
Please,
honored.
yes, absolutely. Thank you.
How sweet. I wanted to take a question. I know this was a conversation at one of the past conferences, and I think you know more about it, but it's from Kathy H. at 12:05 your time, Fran. And it says, please let us know what you know about the Bergen method for OCD treatment, a 4-day intensive method. Are there any trials in the US operating currently?
Yeah, so Bergen was actually, the pilot took place right here at McLean OCD Houston, and I know they are still working on analyzing the data. I haven't seen any of that the final data kind of published or the research out and about for us, but at this time there are not any, to my knowledge, there are not any current Bergen 4-day program intensive methods happening in the US that are Bergen through Bergen. So if you want more information about when they may be coming back to the US or what their next pilots or studies might look like, an opportunity to bring it to the US, you can contact them directly. So you should be able to Google and look up the Bergen method. There are, of course, some providers who became trained in the Bergen method when they were here and did their pilot here at Houston that do some intensive work. And there's a lot of providers across the country, right? You think about people like Denise Egan-Stack and others who've been doing intensive OCD treatment for many, many years where they do this kind of condensed format. So the condensed format is certainly available. A lot of providers do what we would call like an intensive one-to-one IOP. And so that definitely exists in the OCD world. But right now, to my knowledge, Bergen does not have, or I don't know of any plans for when they may restart a America-based program.
Thanks for that.
So let's hop in. There's another question, and then we'll go back to pre-submitted. So we'll go back to Dario at 11:14 my time AM, so 12:14 yours, Fran. I no longer engage in compulsions or avoidance behaviors, overt or covert, which is awesome, but I still experience periods where obsessions feel quite distressing, but they don't interfere with my functioning. What are your thoughts?
Yeah, so Dario, thank you for that question. What I would say first is when I have clients come to me with this and they say, Chris, I'm not doing compulsions, I'm not doing avoidance, but I'm getting a lot of triggering thoughts. A couple things that I usually try to run by first just to weed out. And the first question I do is I like to do kind of like an overview of mental compulsions, because sometimes people don't recognize compulsions as compulsions. A lot of times people will consider a mental compulsion an obsession. So for instance, like compulsive rumination, what I always tell clients is if you got an intrusive thought at 8 a.m., let's say about harming your child, if it's 4 p.m. and you're still stewing on that, that's no longer the obsession. The obsession happened in the morning. Now you're kind of compulsively ruminating. You might be checking in with yourself. Am I going to do something to hurt her? Or you might be focusing on it or sort of tuning out like real life in front of you to kind of contemplate in your head. So that's the first step I'll do, is just make sure that people aren't engaging in mental compulsions, because sometimes they can be hard to notice. If somebody's like, Chris, I'm absolutely not, then the second thing I go to is, how are you responding? If you're already doing ERP and you have that on lock, but how are you responding to just having the experience of thoughts? Because I do know that a lot of times when clients have done a lot of really good work, they're at that point that they're like, I want all my thoughts to disappear and never come. So they're having a great couple days and then a distressing thought pops up. And then they find themselves maybe not engaging with compulsions, but they're frustrated. And they're like, God, I can't have anything. I'm so frustrated. I'm so stressed out. Well, that starts to become a compulsion too. And that negative reaction to the thoughts just brings them back on. If both of those things are crossed out, what I remind people is the treatment is to learn how to live with intrusive thoughts. And those are going to be part of our lives, especially right after treatment for a while. And we get to change our relationship with those thoughts. And what that means is we don't have to engage. And so I know for me, when I finished treatment, I still had distressing intrusive thoughts for like 2 or 3 years after. And then over time, you do still have thoughts. Everybody on the planet has intrusive thoughts. The difference is they no longer cause this kind of like overt like freak out. So just hang in there. If everything else is kind of a no, it's not something that just vanishes once we're done with treatment. It kind of sticks with us for a while, and we just get really good at millisecond response and moving on using ERP.
The last thing I want to add in really quickly about this, because I think this is such an important topic, and Chris and I are planning to do an entire live stream this month at the end of the month with Dr. Grayson on it, is uncertainty. All right. So remembering that sometimes if the thoughts are still really distressing, one of the things I would want to know is, have you leaned into the uncertainty around the core fear? Because what we find is that sometimes if we do target ERP, but we don't address the core fear with uncertainty, we still might find these thoughts pop up in different areas and are distressing. Thoughts are never going to totally go away, but if they're still distressing, it might be indicative that we need to lean into the core fear of uncertainty around it as well. But more to come. That will be, Chris, correct me if I'm wrong, pulling up my calendar. My computer's running so slow, but Wednesday, February 23rd. So that live stream will be Chris, myself, and Dr. John Grayson, where we will be talking about the pitfalls that kind of happen sometimes. So when ERP goes wrong, and we'll be focusing a lot on questions like this.
Yeah, come back to that because we have some good advice for you definitely on that one. I'm going to do a pre-submitted question for you because you are the perfect person to answer that. So we had one of the pre-submitted for Ask the Experts say, what is the next step to take when the adult OCD sufferer will not accept the OCD for what it is and has had IOP years of OCD counseling and even in-house treatment? Where do we possibly go from there? So honestly, that's usually when I refer them to Liz. So that's why I thought this question was perfect for you.
So it's such a hard question. I think if the patient is willing and considering, they certainly need to be looking at a higher level of care. If IOP hasn't worked out, outpatient hasn't worked, and some home stuff hasn't worked, then I definitely recommend that they would consider a residential type of program. So a program like ours, McLean Houston, a program like McLean Boston, Rogers, and Neurobehavioral Institute have some more intensive in-person options. If the question is related also to the fact that the individual isn't willing to take the next steps and the family is kind of struggling with like, what do we do? We've tried certain things and nothing's working. I would recommend the SPACE program for you guys. So it is called the SPACE program, SPACE, all caps, by Ellie Leibowitz. And you can go to their website, in which we'll put a link in a little bit, but you can look up providers in your area. And SPACE is a specific protocol and program that's actually for loved ones to help set boundaries, to help have both conversations and engage in treatment, but also that might allow an individual to realize on their own and to help get them into treatment, right? So sometimes we don't realize that a lot of the things we're doing are enabling or allowing the person to not have to seek treatment. And I'm not saying that's intentional, and I don't think you should stop it overnight, but sometimes with kind of like a really seasoned clinician, they can be your guide to helping you break some of those previous patterns and habits that might also encourage that person to, or allow them to see the need for them to seek individual treatment.
Yeah, the last thing I'll add is there is something called emotional interviewing. It's from Miller, and it was primarily used for individuals engaging in substance abuse disorders treatment. And so they found that a lot of times it was taking people 8 or 9 times in rehab just to get better. And so Miller created motivational interviewing. And what motivational interviewing really did is trying to connect the person with their goals and values to try to understand why they're really engaging in this work. And actually, because I'm a nerd, I printed out a recent study that's all about using motivational interviewing for OCD. So I just started it. So maybe I'll come with new advice when I'm done reading it. But that's really part of this, is if you feel that your loved one isn't engaging in treatment, sometimes the person's never been asked why. Like, what would they get back if they were to engage in treatment? Why would treatment be good for them? One thing I do with clients that are resistant is I ask them specifically, what is it that you miss because of OCD? And I had a client once who's very resistant who said video games. And I said, good. All of our hierarchy is going to be all about getting you back to video games. And so we literally spent sessions just getting them back to playing video games. And they were going through exposures to get to that point. And once they were there and saw how ERP worked and opened up video games for them, they were way more likely to then turn around and do other ERP for similar stuff. So that may be something that's helpful as well.
And I think that's another call to action for Chris and I, is to think about really doing a specific webinar on greater good and motivation, because we talk so much about just how it's critical. Like nobody's going to want to do treatment if the goal is just reduce your symptoms and get better, right? Because we'll want to, in the sense that we like the idea of our symptoms getting better, but we don't like the idea of what it's going to take for them to get better. But if we know that doing that means we can get these things back, or we can have this important life again that we want, that we miss, that we no longer can do because of OCD, it becomes more worth it. So, all right, let's keep hopping in. I know there's so many questions, so we're going to try to get to them. So let's hop to Laura Brown at 11:16 a.m. Please help. I'm in the UK and my son has severe OCD, which isn't textbook, as he has diagnosed as well with autism. I'm desperate. I can't cope and don't know what to do. I'm involved in his rituals. I'm cleaning all the time. I'm now off of work as a nurse and I'm struggling. I don't know what to do.
Yeah, what I would say first and foremost is there are some differences when working with a client with autism, depending on how the autism impacts the OCD, and sometimes just the person's insight with autism. So, for instance, I've worked with clients where they don't see the OCD as OCD. So, for instance, I worked with a client who really believed in his values of not to harm others. And so he was having a problem with the pandemic because he felt like using sanitizer was killing germs and killing cells and killing bacteria. And to him, that was still killing. And so there wasn't a lot of insight there because he really truly felt it was part of his values. And so what I did is, working in conjunction with his ABA therapist and his team that worked with him on autism, we collaborated and I explained why this was harmful for him to continue on this belief system. So they were able to really work with him. So that's the first thing I would always say is, like, sometimes it does take a team to come together. There's also a lot of really good trainings. I believe you did once, because I watched it. You did a live on working with individuals with ASD and with OCD. What I find is I actually really love working with individuals that have both. I have family members with autism, and I find that sometimes I just have to be a little bit more direct. The nuances aren't always there, or they don't. A lot of my younger clients with autism don't always understand this idea of like accept uncertainty. They can't really understand the concept of just like vagueness. So we have to be a little bit more direct. But I always want to let people know that individuals with autism and OCD absolutely can get better. It's not a bad thing to work with a clinician that has comfort in working with both, just so that they understand that. And what the treatment is really going to help you do is find ways that you can start to slowly pull back on the rituals you're involved in. Because I know as a mom, you're so desperate to help your son. You love him and you see him feel better and relieved when doing those compulsions. But as you're probably starting to recognize, is it's becoming something that's getting worse. You're spending more time doing it. And now that you have time off, it's almost like you get to jump in and give the OCD just as much of an audience. So if he's working with a clinician, it would be great to have you come into the sessions and specifically work on ways that you could pull back and he can step up. And by coming up with that together, there won't be that animosity and anger when you're pulling back.
100%. And I did put a resource. I would also recommend that you check out ocduk.org, just because I know you're in the UK and there may be some specific, like I know here in the US, there are specific providers who specialize in comorbid condition of ASD and OCD. And for a lot of us, we will refer to those providers because they are going to be much more equipped to handle these cases than those of us that treat just OCD or somebody who treats just ASD. All right, Chris, at 11:19 from Peach. My 10-year-old daughter has recently been diagnosed with OCD. We have not revealed this to her. I do not want her to identify herself with OCD. What is the best way we can go about it? I love this question because I've been seeing this a lot. And both Callie, who's another provider, and myself, we're talking about this week, where there's been a lot of new diagnosis for adolescents and teens and parents struggling with how to discuss that with them and what it looks like. So Chris, I'd love to hear your thoughts, and I'll share mine as well.
Yeah, it's funny because the pre-submitted question I was going to go to is basically similar to this. It was somebody asking, like, it's really hard for me to grasp that I have a mental disorder. How do people come to grasp with it and not have it define them? You know, when I was in my grad school and we had a whole conversation about the DSM, there was people that were like, I hate DSM, I hate diagnosis. And I was like, well, as one of the people that has a diagnosable disorder in this room, it saved me. And so, you know, I've had clients come into my sessions where the parents are like, please just say they have anxiety, don't say OCD. Or I've had clients where they have OCD and autism and the parents are like, don't tell them they have autism. And what I always find is it doesn't end well. The person is very confused why there's certain things that they're struggling with that other people don't experience. And so your daughter is probably recognizing, Peach, that there's certain things she can't do that her siblings can do, or she's struggling with things her other classmates, aren't, or the teacher is getting frustrated, and all those different things. And so I get it, though. You do not want your daughter to walk around with a big old OCD on her forehead. And so what I really explain to people is that they are an individual, like person first language, like they are an individual who happens to have OCD. And it's definitely a disorder that has a great treatment for it. And one of the things that we first do, especially with kids, is we have them name the OCD. We have them draw it. We start to change language in the house. And what it really helps to do is to separate themselves from the disorder and just explain to them, like, this is something you're dealing with. And by getting treatment this young, I see a lot of clients that they have really minimal symptoms as they progress. So, I know it's really difficult to do, but I can just say from personal experience and clinical experience, I've never seen it go well when we hide diagnoses from somebody who has one.
No, I totally agree. And I think that I agree with the fact that as a parent, I understand the anxiety, right? I understand where it comes from, of like, we don't want them to have a label, or we don't want them to think it means that they have a disability, right? And I am on board with that, right? I do not think any of us should use the language of like, oh, you have OCD, you're going to have a chronic illness forever, right? Like, children don't understand that, and that's going to feel really scary. But as Chris said, can we explain it of like, hey, like, this is where your brain's kind of misfiring, and this is where you're struggling, and we call it an OCD monster, whatever we call it. And the more we can actually label it for what it is, we can also engage in proper education. So like Dr. Pinto Wagner has a great book called Up and Down the Worry Hill, and I know Callie wrote a book called Anxious Annie, but there's a lot of really great kids books that are perfect for a 10-year-old that would allow them to allow the stigma to be decreased. And my anxiety is that when we skirt around the issue, we actually perpetuate stigma, because what we're teaching is that it would be bad if you have this diagnosis. It would be bad if you have this label, versus, hey, here's what you have and here's great treatment and let's address it, right? If your child had a broken ankle, would you hide that, right? Would you tell them that it's not broken and it's okay? Or would you be honest of like, this is what's going on, here's how we address it, and here's how we're going to be able to fully function in the future if we use these tools now? And that's how I want us to talk about OCD. And I think the more we're using open language, we are also engaging in destigmatizing work, which is really important, right? And so, yeah, there's so many great education. And again, there's OCD online conferences. There's so many ways now for there to be this great connection, and for it not to have to be this scary conversation or diagnosis.
I just want to drop two things real quick. One of the IOCDF keynote speakers was the kids that were part of Chris Baer's film for kids. It's Unstuck, an OCD kid story. And I know a lot of my clients that are young, I play that as one of the first things we do in session, and they feel so heard and seen. The second thing I'm going to plug is the IOCDF has a kids camp that was just recent. And I was one of the moderators of some of the breakout groups, and every kid kept saying they were so happy to be there because they finally met other kids with OCD. So local support groups, online conferences, it helps normalize it for her, and she's not going to feel different. And some of the kids were like, I found other kids with OCD and we're best friends forever. So I know it's scary, Peach, and Liz and our, as kids that were struggling, our hearts go out to you. I just want to let you know, just from insider's perspective, Liz and I would be not where we are today if everything was kind of hidden from us.
100%. The more we can be open and honest. And what we know actually is that this generation is more open and talking about mental health than any generation before. And so I think a lot of the anxiety we have, they might not have that same anxiety around mental health because their friends and different folks that they know and connect with are already talking about it in a way that we didn't growing up. So I see some other questions and thoughts that most of them have been answered. A lot of you sharing different stories and experiences. One of the things that Phil asked at 11:22, he talked a little bit about just the ignorance of OCD among mental health professionals, and wanted to hear a little bit about what we've experienced. And so I'll answer quickly first, Chris, and then let you hop in. I think that, there's been so many things that I can get stuck on of like, why did that happen? Why would someone explain things to me in this way? Why would someone say the things they did? A lot of it around kind of disabling conversations of like, you'll have this forever, you're always going to struggle, you should accept that you're going to live in a group home, like all these things that I don't know why someone would say that. But what I also know is that watching where OCD treatment is now compared to where it was when Chris and I were first seeking treatment, it is so inspiring. And I'm a much bigger person of like, let's talk about what we can keep doing versus focusing on what's been done wrong or what wasn't done enough. We know that OCD is still misdiagnosed, undertreated, and underserved disorder, but we're making a difference. And that's why we do these talks.
Yeah, and Phil, I don't know if you saw, but in the last issue of the IOCDF's newsletter, they graciously printed part of my grad school thesis, which I directly talk about this, and I used to, stats and numbers and scientific research to show that unfortunately, what happens is the average person who's dealing with OCD goes to just like their general practitioner, their doctor, etc., and they found that 60% of the time, those individuals, those healthcare workers, were misdiagnosing OCD because they had no training on it. And then they found that second line is providers that can prescribe medication, so like a nurse practitioner or a psychiatrist, and they found that 60 to 70% of those individuals were better obviously at diagnosing, but they only prescribed medication, never even talked about behavioral therapy. So you're right, there's a big lag in the understanding that OCD treatment, the gold standard is ERP, and yes, it can be in conjunction with medication, and how to properly identify it. So one great thing that the IOCDF has is the BTTI, which is the Behavioral Treatment Therapy Institute, and that's educating providers in different areas to start to be able to identify, diagnose, and treat OCD. So IOCDF is doing everything they can. We have the local affiliates like here in OCD SoCal trying to do that as well. But you're absolutely right. I mean, Liz and I will say it's gotten a lot better, but it's still astonishing how many clients, at least I get, that have been in a talk therapy situation for 7 or 8 years and haven't gotten better from from OCD. So.
Absolutely. So lots of different questions. And one of them, Lisa, I'll kind of answer a couple of these quickly, Chris, so we can also get to the virtual doc. But Lisa, I think that I absolutely agree that I really do think your son needs to be with a specialist and somebody who specializes in both OCD and ASD. As far as depression, social anxiety, sensory processing, I think somebody who specializes in OCD and ASD would be able to address all of these different issues that you're discussing, and potentially including ARFID, although they may also want to pull in an eating disorder specialist. But this is where team approaches are so useful, right? A lot of us do not work in isolation. There are multiple team members working in conjunction, sometimes within a clinic, sometimes with other clinics. And so really start to think about starting with someone who specializes in OCD and ASD and go from there. Sana, I'm not sure exactly if you're asking about connecting CBT with sexual intrusive thoughts for OCD or specifically with sexual disorders. I know that sexual disorders are not my specialty and background, but I can absolutely see where CBT would be a really useful intervention. But we definitely have a lot of webinars and live talks on sexual intrusive thoughts with OCD and how to address those from an ERP standpoint. So I would recommend checking out the YouTube channel of IOCDF if that's what you're referring to. But if it is specifically for sexual disorders, I think Chris and I would both say to really go more to somebody who specializes in sexual disorders and CBT work with that population.
Yeah, I'm wondering if they're talking about maybe sexual intrusive thoughts or...
That's what I'm wondering. So if it's sexual intrusive thoughts, we have a ton of content and we'll continue to address that because we address it with ERP. So we engage in active ERP and uncertainty scripts as sexual intrusive thoughts if they are due to OCD, right? So these unwanted sexual intrusive thoughts followed by repetitive behaviors, which are really common for those of us who live with OCD. Thank y'all for all your amazing comments. So much good stuff.
I have a question that I can throw out there. So it's somebody who says, I am 16 years old. It was at 12:27 on YouTube. So 16 years old, they have straight OCD, which I'm guessing is sexual orientation OCD, where you have intrusive thoughts that you might be straight. Can I get completely rid of OCD? Since I got OCD, I can't even date. So there's a lot in there. So, first of all, we just did a really great, we're so happy for our guests, our Lunch and Learn last week on sexual orientation OCD. And this is why it's such a great point to have, is because there's individuals in the LGBTQ community that also question their sexual orientation and gender identity. And I've worked with clients that are like, look, I know I'm gay. I came out when I was like 12. And now I'm having intrusive thoughts about potentially wanting to date women. And I don't feel comfortable even dating men anymore because I'm really struggling. And so that's the point of sexual orientation OCD and the treatment for that, which is sitting in the uncertainty of maybe never 100% knowing your sexual orientation, but choosing to go to your values. So if you have a desire to date, other boys your age, then going for that despite that. But as for the completely getting rid of OCD, I'm going to toss that to Liz because I think that's a question we get a lot about cures or getting rid of it completely.
Yeah, I think you just answered it perfectly, which is what I would say is that we may not be able to totally get rid of OCD because one of the core components for OCD is intrusive thoughts. And we all have intrusive thoughts, whether you have OCD or not. We can't stop ourselves from ever having an intrusive thought in our life, but we 100% can get to a point where OCD doesn't make choices for us in our life. And so if OCD is making you feel like you can't engage in values-based activities or you can't date who you want, that 100% can be addressed and can be something you can have full freedom from.
Absolutely. We have another great question at 1227. It's from Alexandria Chapes. And she says, I'm dealing with uh, intrusive thoughts primarily about suicide. My greatest fear is that I'll break down, lose control over my mind and body, and harm myself. It plagues them daily.
Yes. And then I saw the second piece is, or I do have a therapist that I go to regularly and they're amazing. Any advice on the fear topic? I notice the intrusive thoughts are worse when I'm home alone. All of this makes sense. It makes total sense that the thoughts are worse when you're home alone, right? For all of us with intrusive thoughts, the more we are isolated and alone, the more time the thoughts have to be there and to be present. And so we certainly I would recommend staying busy and having a schedule, especially early on in treatment. But I want you to be working specifically with your therapist, but we can do specific ERP around this. So it's really all about leaning into the uncertainty, sorry, y'all, that we don't know whether or not one day we might lose control, right? Like that's what we're leaning into the uncertainty around. It doesn't mean that we accept or become okay with the thought of hurting ourselves, right? That's not our goal of treatment, not what we would want, because it's not something you want to do and it's not something we would want anyone to be okay with. But what we have to be okay with is where OCD is latching on, which is the uncertainty of the what ifs in our future. What if one day this happens and then it leads to this and leads to this and leads to that, right? It jumps to these worst case scenarios. We want to lean into the uncertainty that like, yeah, who knows what might happen in the future. I may or may not lose control and I'll figure that out at that point, because that's really the uncertainty is we're leaning into the fear of losing control, which then goes to the ultimate fear of what if I hurt myself? But we don't want to be okay with hurting ourselves, right? It's very much like pedophilia OCD. The goal is not that you become okay with being a pedophile or that you accept that you might be a pedophile. And some people have people do this in treatment. That is not how treatment works. Chris and I and Callie submitted a talk on this actually for the foundation for the conference this year. It's about accepting the uncertainty that, it doesn't mean we become okay with our worst fears. We wouldn't want that, but it becomes okay with us accepting the uncertainty everybody else accepts, which is that we have no idea if one day in the future we might lose control, right? And the more you lean into that, the more your insight will increase and you'll be able to see like that's an OCD thought, not reality. So we address it with ERP and you should be addressing it with your provider. But of course, we want you to go slowly and systematically. We don't want you to start with the highest level, scariest thoughts or triggers around this fear.
I'm going to add two quick things. One is remember OCD always attacks the things that you care about most. And so a lot of times when I have clients that have this obsession, when I talk to them, it's because they're in a good place in their life and they really are happy and they're afraid that they're going to lose it all and just snap and take their lives. So always be on the lookout for, regardless of subtype, that OCD is going to attack the things you care about the most. And then the second thing is when you're finding yourself asking about a question in the future, really start to challenge that and recognize that as OCD, because remember, the more we can live in the day-to-day moments and be present and be mindful of our current experience, the less power OCD has in that. If you're finding that the majority of your thinking throughout the day is about something you may have done in the past, like real event OCD or future snapping and taking your life, etc., then recognize that OCD, that is all mental compulsions. That's the ruminating, that's the mental review. You can't live your life always in the far future or the far past. So part of that disarms OCD is the more that you can practice just being in the here and now and not answering those pesky what if questions.
Totally agree. So let's hop in. There was a couple questions about how to approach. One is how do you have the right approach, or what is the right approach of a parent to children with this problem? So how do you approach parents of children with OCD or anxiety?
Are they asking, like, as a parent, what's the best way to handle their kids
I
with
think they're
OCD?
saying how would they give advice to a parent of somebody with a
Oh.
child with OCD?
Yeah, one of the most profound things I ever heard is in our family group one time, this was back when it was in person, there was a lot of parents that were tiptoeing around the issue about OCD with their kids and saying, my kid's not really engaging in treatment. They're okay some days and not others. I don't want them to be stigmatized. And there was a kid who stood up, I think he was 13, and he said, you know what? I suffered with OCD for many years, and it wasn't until my parents took it seriously that I took it seriously. and then I got help, and now I'm so much better. And so what I would say is, as a parent with a kid with OCD, your mom was brilliant when she spoke to our family group, Liz. Your mom said it best, and my mom said it. It becomes sort of your kind of priority in that moment. And, obviously, in a perfect world, we want to engage our kid in treatment to find value in themselves. But if it's a child, your responsibility as a parent is really to get them the health care they need. Just like if they're going through cancer, just like if they, broke their leg, you would rush them to the doctor. So it's really about using the IOCDF's Find Help search engine, engine to find somebody who specializes in the treatment. And what you want to really work on, and by having a therapist involved, is staying the parent. It is, as a parent, it is your job to obviously like support and love your kid, and then let the therapist be the person working on the treatment. So that would be my biggest advice: is continue to be the loving, supporting parent that we know you are, and let the therapist be the therapist.
That's right. Be the support, be the parent, not the clinician. A lot of people giving great comments, not necessarily questions. There was one question that Adam asked about eating disorder and OCD, and we were actually just talking about this yesterday, that we are going to be having an upcoming town hall as well as a lunch and learn specifically on eating disorders and OCD. What I will say is that we do want eating disorders and OCD to be treated often in conjunction, but the treatment is very different. So we would not encourage you to just use OCD treatment for eating disorders, or to just assume that eating disorder is a byproduct of OCD. It needs to be addressed individually, and it needs to be addressed with specific eating disorder interventions, which are a specific type of CBT, as the evidence-based intervention for eating disorders.
And I'll say, Adam, I believe that you were one of the people that submitted, because we got a couple submissions on orthorexia and eating disorders. So I want to let you know that we definitely aren't skipping over this because we don't want to answer it. It's because we actually loved the idea so much that we're doing a town hall and a lunch and learn. So we promise, please come to those, Adam, because we got a lot of people asking about that, and we want to definitely give it the focus it deserves.
Yes, and I am going to, if y'all hear me clicking, it's because I'm trying to look everything up, but I am going to try to find the date that we are planning to do that, so that we can let you know that in a second as well. So next question I want us to hop into is, there's so many questions that I'm like, what do I do? Do I do the pre-submitted ones or this? But let's hop into the last two here, and then we'll go to pre-submitted questions. If you have questions that we don't get to today, please, please, please go to iocdf.org/peace of mind. You can now submit questions specific for live streams. And so this live stream is Ask the Experts. It's twice a month on Wednesdays at noon Eastern time, where Chris and I come and answer questions. You can put them there. You can also put them in the general questions, but we did get to all the Ask the Expert questions, which is great, but we'll help get to some of the general ones as well if we can. But a couple questions. One, we're worried that he'll never accept and let the OCD voice stop being the loudest. Where would we possibly go next?
Yeah, one of the hard things, I think it's probably the hardest thing being a clinician, is because as somebody who's lived through this and I've seen myself get better, is when I work with somebody who absolutely doesn't seem like they want to let the OCD go. And one conversation the first thing I asked to someone is, if you were to let this OCD go, what would be your fear? If we were to absolutely be able to wipe out OCD, the majority of people love that. What do you fear about that? And what some people will say is that they think the OCD keeps them safe, or the OCD doesn't feel like a disorder, it feels like themselves. Or they'll say that, look, I would be lost without the disorder. So sometimes it's finding out, like, what exactly do they see as value of keeping the OCD around? Sometimes, you can do everything in the book, and let's pretend you do everything right, Melanie, and somebody is still letting OCD voice being the loudest. What I've seen happen, and sometimes what has to happen, there's actually a really good research study that I used in my thesis. Sometimes what has to happen is, unfortunately, the person, as family members and stuff, pull all the reassurance and the enabling, etc., is sometimes they have to kind of hit that rock bottom to finally recognize that this OCD they had been giving so much effort to actually ended up causing them to hit the lowest point of their life. And sometimes then, and only then, are they willing to come to family and say, you've been right for all these decades. Like, I'm really ready to get treatment now.
Absolutely. Next question is somebody, Melanie at 1146 also, well, I think Chris answered kind of both of those in one. So let's hop in to the next one at 1147 is, can heterosexual OCD, sexual orientation OCD, potentially change somebody's sexual orientation? Great question. We will definitely be getting to this more in the future, as I know we're going to do some specific lunch and learns, continue them on SO OCD, but Chris, thoughts?
Yeah, you know what, and thank you for this question, because I think we can even blow it up even further. I mean, I've had clients ask me like, look, could having obsessions around pedophilia get me to a point that I like kids, or can, hit and run, can I get to a point that I actually see value in running people over? And, without giving too much reassurance, but I think we can give assurance once, the answer is no. And that's what's great about this disorder, is it doesn't have the power to absolutely change us. What I always tell my clients is the only power it has is of suggestion. It can drop in a little suggestion in the suggestion box, and then us as the individual have the choice to pick out the suggestion, open it, and freak out, or to simply stop going to the box. So in this case, no, sexual orientation doesn't have that power to potentially change sexual orientation. What it does have the power to is add doubt and confusion and uncertainty around your sexual orientation. And that's what's so great about the work the lunch and learn that we're going to have with Dr. Grayson, is he talks a lot about embracing uncertainty. I feel like he was really the pioneer speaking about that. And so it can't change it. And what I always remind clients, the more compulsions you do, compulsions equal confusion. You'll be more confused about your sexual orientation the more you give into the OCD. Once you stop trying to figure it out and you drop it, that's when your clarity will finally come.
The point of OCD treatment is not to make it where we make you believe something you didn't believe, or where we give you new ideas. The point of OCD treatment is to allow you to have the freedom to no longer live by OCD's rules. So the goal of treatment is that you get to live by your rules, your decisions, the way you want to live your life, not OCD's. And I think that's a really important distinction. Okay, so I know, Levlana, one of the questions you asked, and sorry, I was not avoiding it, is you said, you asked a question about if it really is true that we feel like we could help somebody with ASD and OCD work on their compulsions, I believe was the question. And I just want to say absolutely, right? So treatment does look different. And the way treatment, or even the treatment goals, might be different for somebody with OCD and ASD compared to somebody with OCD. But I absolutely believe that their OCD can get better. And I have seen it happen as long as it's a specified protocol that we're doing together.
And I just want to say, like I said, I like working with clients with autism, and I have family members with autism. And I think it's because, it's like they want to get better, and they're very like upfront, and they're very honest. And so there isn't sometimes like that kind of holding back that I see with clients who I don't have autism. And my little nephew has autism, and we're starting to see signs of OCD. And I've been giving kind of coaching to his ABA therapist, and because we can't work with families. So I've been kind of giving direction to the ABA therapist and stuff, and we're already seeing some change. So it's absolutely 100% can happen. So have hope, have faith. There's about 30% is what the research shows comorbidity, meaning individuals with OCD and autism, about 30%. There's a lot of really great talks that have happened at the IOCDF, but I would strongly encourage you to go to the YouTube channel, IOCDF's YouTube, and type in ASD or autism, because I know Liz did one, but I think there's been one or two others too that you can really watch, where they spend a whole hour on this subject, and you can see that people do get better. I've had clients that have gotten so much better that have both.
Yeah, and there's absolutely at the conference lots of talks on this as well. So yes, so many great comments. Thank y'all for sharing. Gonna keep going because I want us to get to the last couple before we wrap up. At 11:48 from Behzad, he said, "I'm an OCD specialist in Iran." Thank you for joining. That's so cool. So excited to see that. A country with a probably double rate of OCD compared to most countries based on recent studies. That's interesting. I haven't looked into that, so I would love to see more about that. My question is how clinicians can reduce the cost of misdiagnosis of OCD in a country where psychiatric service isn't covered by insurance. So this is a great question, and there is no. I wish I had a specific answer, and Chris and I could share lots of different thoughts. And actually, Chris, I think we should do a lunch and learn specifically about like cost of treatment, navigating treatment, utilizing insurance, and bring on some really great expert advocates in this arena, but also folks who help navigate that insurance process that can talk about it. But as far as how clinicians can reduce the cost of misdiagnosis, it really, to me, comes back down to education. The more we can engage in appropriate education so clinicians know what to look for, how to assess, and what treatment looks like, we can hope that we can start to lessen that gap in time between the time someone has symptoms to when they get proper diagnosis and proper treatment, which we know right now in the US is about 12 to 16 years. And I'm a big believer that it starts with education. It is not going to be that we train every mental health provider on OCD. While I would love that, it's not feasible, right? Because being a specialist in something takes a lot of training and a lot of education. As Chris and I would say, like, we're specialists in OCD. There is no way I could be a specialist also in schizophrenia or in bipolar disorder, right? Like, that's not my expertise and background. I don't have enough brain capacity to
time in the day.
or time in the day to be able to do that appropriately. And so, but my goal is, can clinicians across the board get a good education based on OCD so that they know how to assess for it and they know how to refer out, right? I know how to refer for assess for psychiatric or psychotic illnesses, right? We should all be doing that in our clinical intakes with patients, and we should be referring out. OCD needs to be the same, where we're able to kind of quickly not just say it's anxiety or not just say I don't know what's going on, but assess for OCD and know what to refer to. So to me, education is where it all starts. And the reality is the US isn't much different. We have some psychiatric services that are decent, that are covered by insurance, but most are not. And so navigating the system is really hard. But foundations like IOCDF do partner with international groups. And I'm not sure if there's a group in Iran, but if you want to help be a part of that, please reach out to IOCDF, because I know we'd like to expand resources over there as well.
You answered it beautifully, and I want to add a small little thing. You know, one of the presentations that we submitted is a talk on how to better educate society on what OCD really is. And what I would say is I've been always kind of waiting for like this big thing to happen where somebody comes out of the woodwork and like educates the public. And I think what I've recognized in all my years of advocacy, it's not coming. It's going to come from us. It's going to come from the community. So the more that we can advocate for what OCD truly is, the more that we can talk to doctors that have misdiagnosed us, or the more we can educate practitioners, or for you being a clinician who specializes in OCD, the more you can talk to colleagues and go to conferences. We go to the NAMI conference to make sure there's OCD representation, and we educate so many people there. So the more our community goes out and educates the public, that's where it's really going to come from.
Totally agree. And I want to answer a question that Grover said, or he said, certified peer specialists who have OCD spectrum issues is a frontier treatment for OCD. Can you speak about this? And I'm not quite sure what the question is, but here's what I will say. Chris and I definitely need to do an Ask the Expert, where we focus a little bit more on the beginning of this question in detail of like how to find an appropriate clinician for your diagnosis and what that looks like. I cannot emphasize enough how important it is that no matter what, you are working with a licensed mental health provider who specializes in OCD, not somebody who just says they treat OCD and they treat 30 other things, but somebody who's really had the appropriate training and background. That doesn't mean there can't be other ways to like do adjunct treatment or in addition to, and that might be really useful. And a lot of OCD specialists do use like ERP coaches to help with some additional work in between. But I 100% want you seeing a licensed clinician who specializes in OCD as the main primary point of contact that's really guiding your entire treatment plan and your entire treatment process. But Chris, let's plan that our next Ask the Experts. Let's start with this topic first and spend a little bit of time really educating people on what questions to ask, what to look for, how do you know somebody really specializes in OCD, and go from there.
Absolutely. And it's sad that so many people will put on their website that they treat OCD, and then you see that they have 48 specialties. And I think you said it beautifully earlier, Liz, like you and I eat, breathe, and sleep this. Conferences, I'm constantly printing out like that motivational interviewing for OCD. I'm always like finding new research studies. How can I, do it? I learned from our, lunch and learn sometimes from the clinicians. There's no way, unless I just don't sleep, that I could suddenly specialize in something else. So it's super important to get somebody who really, really knows this disorder and the treatment.
Absolutely. I love also seeing we have someone from Pakistan. I will say, Ali, Monica Williams did some great trainings that Chelsea helped organize through Peace of Mind that we funded for a couple providers in Pakistan to be OCD specialists. And so you can absolutely reach out to Chelsea at the International OCD Foundation, and she might be able to point you in the direction of some folks who really have some good background who might be able to educate other providers in your country. The last thing I want to end with is there was a question from Peach that continued about how do I talk to the schools then, and how do I talk to the teachers? And this is such a great question. And IOCDF has made it a mission to provide incredible resources. So you can go to iocdf.org/OCD in the classroom. I think that's right. Fran, I'll let you put the right link. It might just be ocdintheclassroom.org, which I think is what it is. So I think I was wrong. But Fran, if you don't mind putting the URL, it is an entire website that was developed just for this. It has resources, content, education that you can actually point your school systems straight to this website for them to learn more and understand. And of course, with the therapist, whoever your daughter is seeing, they should be, or your son, I can't remember, but whoever your child is seeing, they should be working with the therapist who should be working with the school, and it should be a collaborative process. Don't feel like you have to take this on your own, because it will feel really overwhelming. So I'm going to quit talking. I've babbled too much. Chris, I'm going to let you wrap up, but thank y'all so much. As always, this was engaging. It was intriguing. And most importantly, it was so inspiring. Please go to iocdf.org/peace of mind to submit any future questions. And we will be sure to always get at least the Ask the Expert questions answered. We might not get to all the rest, but we definitely always get to those. I want to leave everyone with a message that help and hope are always available. Don't lose sight of that. Chris.
I decided that one day we're going to do like a marathon. Maybe we'll throw on Ethan with us, and we're just going to go from like 8 a.m. to 8 p.m. So then we can get all the questions answered. But
eat lunch together. We'll chat together.
Restroom break. Yeah. I want to say to everybody that asked a question, I mean, I love that you come out and you support Liz and I, and you really engage with us and you ask those questions, and we try to get to all of them. But one thing we do, if we didn't get to your question, we go back, we highlight them, we put them in this document that I have open on the side of my computer that has all the questions we don't get to. And we're going to consistently get to them, or we're going to do a lunch and learn so we can go more in depth in it. We're going to always be there for you. Thank you so much for everybody that came out, engaged in the comments, engaged with each other and asked questions. It's absolutely a blessing that Liz and I love to do this for you, and we're always happy that you show up. Definitely go to iocdf.org/peace of mind, as Liz said, or iocdf.org just for general information. Next Wednesday, remember, you always have, we love this consistency. You always have a live stream Tuesday evenings at 7 p.m. Eastern time. It's going to be community conversations, town halls with advocates. And then on Wednesdays at noon Eastern time, you're always going to have clinical backed conversation. So next Wednesday, Liz and I won't be here because you're going to have the great Kyle King, and you're going to have Dr. Abramowitz, who are going to do a researched roundtable. And then we'll be back for an Ask the Expert after that. Everyone have an amazing rest of your day. Fight OCD because it sucks, and we love you, and come back to Ask the Experts. And it's always good seeing you, Liz.
Great to see you, Chris. Thanks as always. I love having you on the screen with me, and can't wait to see you guys in 2 weeks.
And Just Right OCD, I saw that, Aaron. We will put it in our list. Take care. We'll see you back in a couple weeks. Bye.